organized educational webinar series. The ninth instructional webinar is underway today, supported by Norman Barman. This webinar has the endorsement of the Mean Stroke Association. The topics of ischemic stroke and cerebral venous thrombosis have dominated the last 8 webinars. We will switch today to discuss the hemorrhagic stroke. If you want to learn more, watch the next minutes. As a part of Iraqi Stroke Network NAT team, my name is Al-Sultani, and I work as a neurologist at the Imam Hussein Medical City in Karbala. I'll give the floor to our panelist, Dr. Mohammad Kurmanji, a fellow neurovascular interventionist and assistant professor of neurology at Suleimania University College of Medicine. For the time being, Dr. Mohammad, the word is yours.
Bismillah ar-Rahman ar-Rahim. Wassalatu wassalamu ala Sayyidina Muhammad. Assalamu alaikum. You can't hear me?
Wa alaikum salam. We can hear you.
Okay. Bismillah ar-Rahman ar-Rahim. والصلاة والسلام على سيدنا محمد وآله الطيبين الطاهرين. نعزيكم ونعزي أنفسنا ونعزي الأمة الإسلامية بذكرى استشهاد سيدنا ومولانا الإمام الحسين عليه السلام. On behalf of the Iraqi Stroke Network, welcome all our guests and colleagues, especially our kind speaker, Dr. Aqueel, and our kind colleagues, also Dr. Yasser Hamandi, the head of the Iraqi Neurosurgery Board Committee, and all other colleagues, to the regular scientific webinar organized by our network and sponsored by Norman Company. The Iraqi Stroke Network is keen on the program of continuous scientific development and update of acute stroke management and neurointerventional procedures. And in order to encourage our neurologists to benefit from the rapidly developed scientific skills in this field, and in communicating with our specialist colleagues outside Iraq and inside Iraq to learn about the latest developments and research in this field. As we know, still Iraq is deficient from this interesting life-saving field, in spite of the presence of few kind scientific, well-trained colleagues in Baghdad, in Basra, in Erbil, that they dealing with neurointerventions, interventional cases and neurosurgical and neurological cases that need intervention. But still, this is not enough to cover the big need with the absence of the highly authorized official entities to support this field that we hope to be solved in the near future. As we know, most of the near countries developed well in this field, and we hope that we will be also well developed in this field in the near future. We thank all our guests, our colleagues, our attendees who joined us in this webinar, and we hope to get so much benefit from this webinar. And our regards to all our colleagues and attendees against. And now the floor to Dr. Aqueel, please, or Dr. Ali, to present Dr. Aqueel first. And thank you so much.
Thank you, Dr. Mohammed. I can send the warm greeting to all of attendees and guests of this for this evening, with a special welcome to Professor Yasser Hamandi, the head of Iraqi Board of Neurosurgery, as well as to all of my colleagues as a neurosurgeon. We have a section regarding to the question and A will be led by Dr. Israa Ali. She is a neurologist at the Diwania Teaching Hospital. Dr. Israa, please, can you hear me?
Yes. Good evening. I'm Dr. Israa Ali, and I am a neurologist at the Diwania Teaching Hospital. I will welcome your questions and comments and try to communicate it, but in a best way to the panelists. Thank you.
Thank you, Dr. Israa. Now we are the next part, Dr. Aqueel Hussein Pabaney will be our guest tonight. Dr. Pabaney worked at the Great Hospital and Emory University School of Medicine in Atlanta as assistant professor of neurosurgery, neurology, and radiology. He is the world-trained hybrid cerebrovascular neurosurgeon who specializes in performing intricate open vascular skull case and the neuroendovascular procedure in the angiography suite. Dr. Aqueel has been more than 40 publications in higher medical journals and books chapters in field of neurosurgery and stroke management with H-index of 14. His areas of expertise include stroke, aneurysm, IV formation, myomyositis, cerebral revascularization, and brain and skull case tumor. Dr. Aqueel is interested in teaching and training the neurologists and the neurosurgeons regarding the cerebrovascular and endovascular technique. The word is your Dr. Aqueel.
Bismillah ar-Rahman ar-Rahim. Thank you very much, Dr. Ali, Dr. Mohammad, for your kind introduction, and Dr. Mohammad Al-Sultani for his kind invitation. It is a real pleasure to be here today for several reasons, but most importantly, I feel like we have, at least personally, I have a very strong connection to Iraq. I've been there several times, alhamdulillah, for pilgrimage several times. I've been for Arba'een, and inshallah plan to visit again for Arba'een this year if Imam Hussein invites us, inshallah ta'ala. Without further ado, we'll inshallah proceed with the presentation. Just want to make sure that you are able to see my screen at this time. Are you able to see my screen?
This is here.
Yes, sir.
Okay, this is here.
May maximize this presentation.
Sorry, I couldn't understand. Can you guys see my screen?
Sorry, Dr. Aqueel, it is clear. You can screen full up.
Okay.
Can you move to full screen mode, sir?
Okay. So
Dr.
yeah. So
Aqueel,
yes.
you can screen full that from your computer.
I think I'm. Okay, one second. Let me see. Are you okay?
And the bottom,
The bottom.
like data show in the bottom in your laptop.
Okay. What do you see right now? Do you
This
not?
one, yes, this one. Okay.
Okay. What about now? Can you see it?
I see all the slides.
You're seeing
You
all
can
the
share
slides?
just one slide. Yeah.
Okay. One second. Let me fix that. 1 second. Let's see if we can fix that.
The icon, yes, this.
How about now? Is that better?
No, you can return to the next one. I think it is better.
This is not good.
You will the first one. It is better. Okay, you can continue, please.
Can I help? Can I help?
How about this? Does it look better?
Okay, it is okay, Kamal.
Okay, for now.
You
Okay.
can, sir, excuse me, you can press the F5 button at your
Like
keyboard.
this one right here?
F5 on your keyboard.
You said F5?
Yes.
Okay, let's try F5. How's that?
Okay. That good,
Is that
but
okay?
on the display setting, you see
How
the
about now?
display setting at the head of the slide, the display setting.
I don't know what exactly are you referring to. Sorry.
This one.
The third one.
Third one. Okay, well, you can see my screen here, right? Can't you?
It is okay. It is okay. Okay.
Is that okay? All right.
Okay.
I think we can get started, and hopefully you should be able to see what I have to present. Okay, all right. So so the idea of today's talk is essentially to talk about neurovascular pathologies in general, but because I'm a dual trained vascular neurosurgeon, I feel like I have a strong bias towards folks being trained in a way that they're able to handle cerebrovascular pathologies in a hybrid perspective. And what I mean by that is to be able to take care of both the cerebrovascular pathologies, both from the endovascular standpoint and from an open vascular standpoint. Now, I do understand that there are some folks on this talk right now that might not be surgeons, and so I apologize if some of the surgical videos are not appropriate. But having said that, I feel like it's important for me to present, and especially for the newer generation and the upcoming trainees, to really consider that if they're interested in cerebrovascular pathologies, to pursue a pathway that they can approach these pathologies from a hybrid perspective. And I'll show with some cases what I exactly mean by that. But I think the paradigm is shifting. I don't think that there is any more this fight or antagonism between open surgery versus endovascular versus radiation. I think now it's, you can put all these things together for the patients and provide them with a more tailored plan through multidisciplinary discussions and conferences. I think that's the beauty of a multidisciplinary center that harbors all those physicians and specialists. So this is the hospital that I primarily work at. It's called the Grady Hospital. We are a level 1 trauma center, and we are a comprehensive stroke center. We do approximately 400 stroke thrombectomies each year, which is one of the highest in the country here in the US. So it's pretty high. And then, we do a fair number of open hemorrhagic pathology as well, such as AVMs, aneurysms, AV fistulas, and so on and so forth. And just because I'm a neurosurgeon, I also do a lot of trauma and spine and tumor as well. So just before this presentation or talk, I was actually taking out an insular glioma. So, I pretty much do all, but I love doing vascular neurosurgery the most. As I said before, I've been to Iraq. Obviously, I'm sure you all identify Imam Ali's shrine in Najaf and Bain al-Harmain in Karbala, and I've been, alhamdulillah, I've been blessed twice now to be able to do the Arba'in walk. And when I was there in Karbala the last time, I was actually fortunate enough to visit a couple of hospitals there and talk to people about offering my services in the future. But that we talked about that last year, but obviously things are still in process. I've not been able to come to Iraq to do a medical mission trip, but inshallah, hopefully this talk will provide a gateway to future collaborations, inshallah ta'ala. So as I said, I don't have any financial disclosures for this talk, but I do have some biases. As I mentioned, I'm a dual trained surgeon. I work with neurosurgeons, neurologists, radiologists, intensivists, and trainees, meaning residents and fellows. And I've been involved in a sort of neurovascular outreach programs outside the US. So primarily I'm from Pakistan. So most of my outreach work has been in Pakistan in several cities, including Karachi, Lahore, Islamabad, and hopefully this year when we go back, we'll be in Multan as well. And we have done some very complex cases, and it's been great because all the work is done pro bono. There's no cost to it. I typically try to take instruments and equipment from the US. I bring them over to Pakistan or wherever I inshallah will end up. And then we try to line up the patients and do procedures on them with their permission, with the hospital's permission. And alhamdulillah, we have been able to treat a lot of patients with complex neurovascular pathologies. So what is cerebrovascular surgery? It's a traditional method of treating neurovascular disorders, which I'm sure some neurosurgeons in Iraq have been doing it for way longer than I have been doing it. But just for our general audience, cerebrovascular surgery primarily includes aneurysm clipping, AVM resections, cerebral revascularization, such as bypass. The surgeons are also sometimes the bailout or the last option when all the endovascular techniques have failed, and we'll talk about that. And more importantly, the carotid artery disease, at least in Pakistan and the US, carotid artery disease has primarily been taken over by vascular surgeons. But I think being involved with stroke patients all the time, I feel like the neurosurgeons and the neurologists have to own the carotid revascularization because we understand the end organ better than any other subspecialty. So I'm, at least at my hospital, I'm in the process of reclaiming that territory back, and I do all the carotid endarterectomies and the carotid artery stenting in our hospital, because I feel as a neurosurgeon, I know the brain better than the vascular surgeons, and hence we should be the ones doing these procedures. What's endovascular neurosurgery? Most people talk about that it's a minimally invasive way of treating neurovascular disorders, but the reality is that it's not minimally invasive. It's, if anything, it's less invasive, because once you are in the arteries and you have the catheters up there, you still can cause damage and harm to the patients, and do bad things to them and hurt them or even kill them. And so some people talk about minimally invasive way just as a as an advertising propaganda, so to speak. But we should be very honest and open to the patient that although it's a smaller incision in the groin or in the wrist, if you're going transradial or transfemoral, doesn't necessarily mean that there's no risk. There's still significant risks when you treat aneurysms with coils or stents or flow diversions or do embolizations and so on and so forth. So it's very important to understand the science and the technique, but also important to understand and recognize what are the potential complications that can happen with endovascular. Just because there's not a big incision involved like a craniotomy doesn't mean that that there cannot be complications. So the patients need to be aware of this. And as as I just mentioned, in endovascular, you can do aneurysm treatment with coilings, either stent assist or balloon assist, flow diversions. Now we have intrasaccular devices. Obviously, you can help the other surgeons with tumor embolizations or embolizations of AVMs and fistulas, balloon test occlusions for ENT or head and neck surgeons when the carotid artery is involved and they're considering resecting the carotid artery. And then obviously, as we talked about, carotid artery stenting. And then more recently, we've been doing a lot of middle meningeal artery embolizations for subdural hematomas, and as well as intraarterial chemotherapy for retinoblastomas in children. So that has been very, very effective. So there used to be a war between, and as I said, endovascular and open surgery, but I think the time has come that there has to be more of a mutual friendship, and a hybrid neurovascular surgeon would look somebody like this who can do a flow diversion at the same time as they can do a clipping at the same time. So there doesn't need to be either or. It's basically endovascular and open surgery, because we need to be able to present both options and to the patient. But then obviously understanding the limitations in several countries and several setups, that every surgeon cannot be endovascular, but at least in a center that offers or that claims to offer cerebrovascular care, they should be able to offer open vascular and endovascular options to the patients, just because things have advanced significantly in both disciplines. And so I'm sorry, this was supposed to be on an animation, but it's not showing up like this. But what this slide is trying to show is I don't call this cerebrovascular surgery anymore. I call it neurovascular surgery, predominantly because of the involvement of endovascular. But as you can see here, for aneurysms, we have so many options. We have clipping, bypass, coiling, flow diversion. For AVMs and AV fistulas, we have embolization, resection, and radiosurgery. And for stroke, obviously, we have mechanical thrombectomy, we have carotid endarterectomy, stenting, and now more recently TCAR, which is a transcarotid revascularization. So these are all the options in a nutshell that the patients can be presented with and talked about when they present with any of these cerebrovascular pathologies. And so there are several things in the toolbox, right? Let me see if I can do some animation on this, because here you can see, let me see. So you have the aneurysm clips, you have bypass strategies. You can do coiling of the aneurysms, standalone. You can do it stent-assisted coiling. You can do balloon assist coiling. These are the intrasaccular device, like it's called a web device that you can place inside the aneurysm. That doesn't, especially wide neck aneurysms, and you don't need any additional stents or flow diversion. And the results have been fairly encouraging.
Sorry, Dr. Amin.
Yes.
Sorry, please, you can share just one slide.
I'm sorry, what did you want me to do?
Please share just one slide. There are two slides.
No problem, sir. I think it is okay. Dr. Ali. Excuse me.
Okay.
Display slideshow, yes.
How about this? Is this better?
Very good. Perfect.
It's okay. Yeah. Okay. Good.
Okay, Ali, we got it done.
Thank
All
you.
right.
Thank you.
Well, thank you for showing me this mark right here. That's excellent. Okay. All right. So now, is that okay now?
اوكي تمام دكتور.
Looks okay. All right. Oh yeah. So
Okay.
this is a flow diversion device, like a flow, like a pipeline or a surpass that you put across the neck of the aneurysm, and it takes care of the aneurysm. And there are different devices now. Like there's something called Contour. This is a Medina device, which is not available anymore. And then this is a Contour device that's more recent. It's called a neck bridging device that you basically just deploy the neck of the aneurysm, and that takes care of the aneurysm. So essentially, as I said, you know, there are multiple options for aneurysm treatment. For AVMs, as you all know, we can do embolization, we can do surgical resection of the AVMs, and then obviously for deep-seated AVMs, radiation is a great option as well. And so, as I said, you know, you just need to have all these things in your toolbox that you can use at your disposal at any point in time with people with complex pathologies. And so let's dive into some of these cases that I wanted to show you, because I think it's they really illustrate the point here. So, so this is a patient that essentially presented with, as you can see here, and I can try to fast forward these if possible. So this is a patient who had a apparently underwent a so-called craniotomy for a left frontal AVM in her hometown of, I think, somewhere in Africa, maybe like Congo or somewhere. And you can see the evidence of craniotomy. There's an AVM there, but apparently they opened when they did the craniotomy, somebody's told them, hey, the patient did not have rupture from the AVM. They had a rupture from some aneurysm, and there's a subarachnoid hemorrhage. So basically they stopped the procedure. So she came to us here in the US because she was visiting family, and she had a severe headache. And so I did her angiogram, and what you see here at the, obviously you see the AVM here, a couple of draining veins here, but then also more importantly, you see this, do you see at the bottom of the screen a anterior temporal artery aneurysm that she probably ruptured from when she initially had presented in her hometown. So, oops. So then obviously, you know, we were like, well, the AVM is not the problem at this time. She has a feeding artery aneurysm that needs to be squared away, or that needs to be fixed, because technically it can re-rupture and she could potentially die from it, right? And so these are some of the other views in there of the aneurysm. But so here you can see the aneurysm a little bit more clearly, as well as the AVM on the oblique projections. So it's really important for, you know, our trainees to understand the angiograms, because angiogram can really reveal the dynamic nature of the anatomy. And so what we decided was, well, this patient, predominantly, what we need to do is we need to secure this aneurysm first, and then at a later point in time, we can go after this AVM. And so what we ended up doing is, because as you can see, there's an aneurysm, and this thing fills up later, so it's more or less like a pseudoaneurysm sort of a thing, so fairly unstable. So what we did was, as you can see, there's some catheters there, which is basically there's a balloon catheter, and then there's a coiling catheter, and we were able to coil this pseudoaneurysm, as you can see right here. So there are coil mass in there that is that you can see right here. There's a coil mass right here. Right there, right? So you see that coil mass in the aneurysm. And so once that was secured, we let her recover, and then we brought her back for another angiogram a few days later. And then essentially, this is just showing the path of our microcatheter that it will take through the MCA, and see how far distal we can go, almost into the AVM with our catheters, and we can inject onyx. So as you can see, here's our catheter. Here's our microcatheter going all the way up into the AVM, as I was showing before. And you can inject onyx, right? So that's a microcatheter injection into you want to make sure that all the embolic material goes into the AVM. So here you can see that AVM right there, right? And with that, you can inject onyx right there. So as you saw the onyx cast, onyx is like an embolic material. And once we did that almost, not 100%, but killed most of the AVM right there. And then next day we took her back we took her to the OR, and essentially I resected the AVM. And then typically when we do this, we do intraoperative angiogram in the OR. That's why this picture looks a little not super clear, but as you can see, the AVM is now resected. So essentially in this case, you know, we were able to employ both endovascular techniques by coiling the aneurysm and embolizing the AVM. as well as then surgically taking care of this AVM. And then, she is about 5, maybe 4 years out of her surgery, and she's doing pretty well. We kept an eye on this residual aneurysm, and this is actually slowly getting smaller because now the AVM is not there anymore.
بس شوفي
Right?
Okay.
So next case, this is a patient, a young lady who presented with this ICA terminus aneurysm at an outside hospital. As you can see, it's a pretty large left ICA terminus aneurysm. And it, they call the aneurysm, which is not unreasonable, which is a good thing to do. But a few years later, she had a recurrence that kept getting worse. As you can see, the coils kept getting compacted here, and the aneurysm kept growing. So obviously, the coils that can happen, and especially in basilar apex aneurysms or ICA terminus aneurysms, because the jet of the blood can just keep hitting on the coils and keep compacting them. And so what we did was, I took her to the operating room, and here you can see the ICA and the MCA, the AC is on the other side. You can see this large aneurysm. You can see some coils in there, and now the clipping obviously can really help us take care of this aneurysm and cure it once and for all. So I'm going to fast forward this a little bit, but here you can see the back wall of the aneurysm. Since we put the temporary clip on, it really nicely softened the aneurysm. And then here's the first clip that is coming onto the aneurysm right there. And you can slowly and gradually clip this, but obviously because of the coil mass, the clips keep on slipping. So you just have to stack the clips until one clip stays, and then you take the other clip off. And obviously you have to make sure that the clip doesn't shut down the MCA or the ACA. And then once the clips get into a position where they want to be, you can puncture the aneurysm to make sure that the aneurysm is completely excluded. So here we punctured the aneurysm and we aspirated the blood out of the aneurysm, as you can see, and that will lead to the aneurysm getting deflated, as you can see there, right there. Right, and then over time it will just deflate and that'll be it. And then sometimes you can add additional clip on top of the first clip to bolster your closure so that there's no evidence of, or there is no chances of this thing recurring again. So as I said, endovascular technique was rightly employed, but for some reason it didn't work for her. And here we're checking that the clips are all the way through, which this clip, the more proximal clip is. Yeah, so that took care of the problem right there. That's just showing that we're adding more clips just because we really wanted to because it was such a big and partially thrombosed aneurysm. And then you can do an ICG angiogram sometimes if you don't have intraoperative angiogram, where you can see the ICA and the MCA are filling up without any issues. So what about some AV fistulas, right? So the dural AV fistulas are obviously complex pathologies, and most of the time we do treat them through endovascular means, but it is very important to know the anatomy, the cerebrovascular, the normal and the abnormal anatomy, and the anastomoses that come into play in treating these. So this is a patient that was actually in prison and was beaten up, and then he presented with an incidental finding. And so on the CT scan, he had a hyperdense structure that was seen, and then they did a CTA, and then eventually we did this angiogram. As you can see, it's a very aggressive fistula where you have a large branch of the middle meningeal artery that is feeding into the foot of this large cortical vein, which has a big dilated ballooning, and as well as like a sort of a daughter aneurysm on the vein. So this is sort of a Borden type 3 where the artery is directly draining into the vein, and it's very high risk for hemorrhage. And then this is a left-sided injection. So this was a right-sided injection, and then the left-sided injection also reveals that the middle meningeal artery is also supplying this fistula, and high pressure cortical venous drainage is evident. And also you can see there's a massive occipital artery that may also be contributing to this fistula, but at this time it was not apparent. It seemed like bilateral middle meningeals were supplying this. So what I wanted to show you here is sometimes you can do things from an endovascular standpoint. So this is just a dynamic picture of this, right? As you can see, there's a middle meningeal artery, And here's a fistula, and then you can see the drainage into the large cortical veins right there, right? So obviously we had to treat this because they're at a high risk of hemorrhage. This is a left-sided injection, as I was mentioning. So again, same thing, draining into the fistula. You have massive occipital artery as well. You can see that here as well. So I'll not belabor the point, but briefly what we did was we went up the middle meningeal artery on the right side, and we injected a lot of onyx that went into the fistula, and we thought that we got a really good result. However, when we did the post injection, as I was mentioning, you see all this massive superficial temporal artery, and the occipital artery now is sending these transcutaneous and transosseous feeders into this fistula, and it's still filling this massive venous varix. And so obviously that the problem was not taken care of. And for those of you who might do endovascular might know that to put our catheters through these occipital and superficial temporal arteries is very difficult, because you can see how tortuous it is. And it's almost impossible to make all these turns and twists to get the catheter close to the side of the fistula. And so what we did was, we actually did a direct puncture of the occipital artery, where the occipital and the superficial temporal artery were draining into this vein. Then you could feel them through the skin. So we used an ultrasound and injected right into that artery instead of trying to get the catheters. And once we were, as you can see here, as we got a direct access through an 18-gauge needle, and when we injected our dye, it showed us exactly where the vein and the fistula was. And so what we did was we injected onyx, or glue, excuse me, through those arteries, which basically went down all the way to the fistula. And as you can see, it kind of like went down all the way to that venous varix, took down this vein, and took care of the problem. And so this is a post angiogram. As you can see, in the common carotid artery, now there's no filling of the fistula whatsoever, and there's normalization of the venous anatomy. So here's the AP, there's the lateral, and you don't see any of the fistula or the draining veins opacifying right now. Next case, so this is a patient that so this is a young patient who presented with a frontal hemorrhage, and on a CTA, he was shown to have this, as you can see near the ethmoids right there, a small venous varix and some busy vessels anteriorly. This is suggestive of an ethmoidal fistula, right? And this is one of the more classic, surgical pathologies, as most surgeons would know in the audience here, because the surgery is very simple. You have ethmoidal arteries that come from the ophthalmic artery, and then they drain into these big veins at the base of the skull. And obviously, it's a very easy surgical cure. Here's the angiogram. I always like to do an angiogram for any vascular pathology that comes to our service, because that's the best way to know what exactly is going on. As you can see here, this is a right-sided injection, but it's more apparent on the left-sided injection. You should be able to see. Here's the left-sided injection, and here you can see the ophthalmic artery giving branches to the ethmoidal arteries that are basically going into the skull base and directly into this big, sort of a sizable venous varix, and with some cortical venous reflux. Obviously, this has hemorrhage, and so it needs treatment. I tried to treat this with endovascularly by putting my catheter into the ophthalmic artery and injecting glue. But unfortunately, we were not able to fix the aneurysm. So here's another view. You see the ophthalmic artery going and supplying this fistula right here. And so once the endovascular, as I said, we tried to treat this endovascularly, but it didn't really work for us. I ended up taking him to the operating room, and you can see, if you have a surgeon on your team, the surgery is very, very simple. You basically do a frontal craniotomy, which we did right here. You can see this is a subfrontal approach. There's a frontal lobe being elevated, and this is the gyrus rectus and the olfactory tract. And here we can see some arterialized veins right there at the bottom, right there. So we're opening the arachnoid around the veins right there. And basically all you have to do is just coagulate them, burn them, and cut them. And that's pretty simple. And so essentially, there's no reason to play with catheters, onyx, and put the patient's vision at risk. You can just essentially just do a simple craniotomy. Takes about an hour, maybe at most, to go down there, identify those vessels and divide them, and that takes care of the problem. And once and for all, the patient is cured. So I like to do some extensive dissection just to make sure there's no residual that's remaining behind. But here you can see the whole skull base, all those veins are now have been coagulated and divided without any significant risk to the brain. So this next case, this is a patient that presented with, as you can see, intraventricular hemorrhage, right? And a small Vermeer hemorrhage. Obviously, she got a CT angiogram and then a cerebral angiogram and a CT angiogram. And as you can see, I'll show that to you in a second. Just going to go to the pathology in the interest of time here. So here you can see there's a fistula that arises from, sorry, my computer's a little jumpy here, I don't know why. But here you can see there's branches coming from the cavernous or the petrocavernous segment of the cavernous segment of the internal carotid artery. This is the meningohypophyseal trunk, and it's draining into this posterior vein. So here's the fistula right here, and it's draining into a posterior fossa vein right there. So kind of an abnormal looking vein. And given that this was a posterior fossa hemorrhage from the CT scan, I can show you that again right here. We know that this was most likely the problem right there, right? And so obviously this needs to be treated as this is a risky fistula that can bleed again. It's a high flow fistula. You have a carotid artery branch draining directly into a posterior fossa cortical vein. But obviously, if you try to put catheter into those small little branches, you're putting you're taking a great risk of pushing the embolic material into the carotid artery and causing a stroke. So, we decided surgery would be the best way. Once again, this is very simple. You do a simple retrostic craniotomy, and as soon as you do it, just like you do it for a microvascular decompression, you can see the arterialized vein right there. There's a fistula right there, the bulbous thing, as you can see. So what I did was, in this case, is here's the facial. You can see the facial nerve right there. The fifth nerve is going to be deeper. We put a clip on the what we thought would be the draining vein, and once we did that, we did an intraoperative angiogram, and that showed us that the fistula was dead, suggesting that we were in the right spot and we have identified the pathology correctly. That's one of the benefits of the intraoperative angiogram. And now we can take the clips off, and as you can see, all these the two arterialized veins right there. And you can just coagulate them and cut them, and it's and the patient is cured. So there's no need to try to put embolic material into those veins because that causes significant risk to the carotid artery and distal embolizations and strokes. And I've known people to try that, but again, if you have a surgeon in your team, then they can easily do this. Here you can see the fifth nerve very, very clearly. So this is the approach we do all the time for that. Let's see, how much time do we have remaining?
Take your time, sir.
I'm sorry?
Take your time.
Okay. All right. So this next case, here you can see this so this is an interesting case because here this is a fistula, which is a very low flow indirect fistula that you can see here. Sorry. Okay, let's see. Sorry, my computer's hung up here. But essentially, what I wanted to show you here, and this is very interesting, there's an indirect fistula that essentially is originating from the branches of the carotid artery, from the cavernous branches, and it's draining into the ophthalmic vein. And typically for the indirect branches, you can sometimes take a transvenous route through the inferior or the superior petrosal sinus. But in this case, we didn't have the availability to do that. And so essentially what we ended up doing was, see if we can restart this program again. Sorry about that.
Okay.
There you go. So here, as I said, you can see the fistula, you can see the draining vein into the contralateral cavernous sinus. So the ophthalmic vein is the only way. So if you know your anatomy, you can actually get a direct access into the inferior ophthalmic vein that will take you directly into the cavernous sinus to treat this. So here, I mean, you can use X-ray to identify your optic canal, your superior and the inferior orbital fissures, and then here's a magnified view, so you can see the optic canal, superior orbital fissure, inferior orbital fissure, and then this is a quick video as to how this is done. You basically make a small incision just lateral to the mid-pupillary line, right, and you push the globe up. Let me show you here. Yes. So here, as you can see here. Once you do that, you make an incision. This is the eye, which is all injected because of the fistula. And under X-ray, you just push the needle on the floor of the orbit slowly and gradually. And here you can see the needle right there. You can see the shadow of the needle, and you can see how we are approaching the foot of the vein. So here you can see the needle advancing slowly right there. And then here we got the blood, arterialized blood coming from the superior ophthalmic vein. Then you can pass your wire into the cavernous sinus, as you can see. So you can see me feeding the wire. You're taking the needle out. Then you can put your dilator in, and essentially just use it like anybody would do a transarterial, transfemoral angiogram, right? So essentially the same procedures. You get your dilators in, put your catheter in there, because you're using the cell-digital technique. And once you're there, this is our setup. And once you're there, right, then it's easy, right? So you can put your microcatheter, microwire, get to the point where you need to go where the fistula is. Then you can put coils, you can inject onyx, whatever you want to do, and that takes care of the problem. So essentially, like, endovascular surgery allows you to be innovative and try to do direct access, either, as I showed you, through the skin or even through the orbit for some complex fistulas. But obviously, you need to know your anatomy pretty well. And so here's the sort of the diagram, the angiogram showing you the coiling and the onyx embolization of the fistula that took care of the problem. Really quick about revascularization. So obviously, revascularization can be done either through carotid endarterectomy or stenting. If it's narrow, you open the artery up and it establishes the flow. But in the brain, obviously, you can do bypasses, because if somebody has giant aneurysms and needs to be, if you want to trap some arteries but you have to provide an alternate source of blood to the brain. And sometimes you can use a superficial temporal artery, or sometimes you can use the occipital artery, or sometimes you can just use a graft within the brain. So you can do an intracranial to intracranial bypass, where you can do end-to-end anastomosis, end-to-side anastomosis, like that, right? So I'm just going to go through that. As we talked about the carotid artery disease, I think, again, neurologists and neurosurgeons are in the best position to treat carotid artery disease. You can do either endarterectomy or stenting. Just a quick video of the endarterectomy, in case, I don't know if you guys do that at your place or Vascular does it, but essentially it's a pretty straightforward procedure, like an ACDF. You go medial to the sternocleidomastoid mastoid, identify your anatomy, find the common facial vein, divide that. You have the ansa cervicalis. I'm just forwarding that. You have the carotid sheath right there, and the carotid artery is exposed. You expose the common internal and external carotids. Right there, it's exposed. You can see the suprarthyroidal artery, and you can put clips on them in a sequential fashion. Obviously, the internal followed by common and then external. And once you do that, you open the artery. Obviously, you can take out the plaque, which you can see that here, like a nasty plaque, and allows you the opportunity to really remove everything and remove all the debris, and then suture it back up. And it's pretty quick and a reliable way of doing things. So here we have essentially close the artery, and you take the clamps out, and everything hopefully should be okay. And obviously the other option is to do stenting, where you put up a balloon, you perform angioplasty, you push the debris to the side, lay the stent down, but the patient needs to be on dual antiplatelets for at least 3 to 6 months. You need to have a distal protection device. Obviously, there's increased risk of stroke with stenting. There's a more increased risk of MI because of anesthesia and endarterectomy. But again, with advanced techniques and advancements in medications, those risks are less than 2% now. So Here's an example. Carotid artery significantly narrowed. We performed the stenting here, and the artery looks as good as new right now. So, and this takes about 30 minutes to do, pretty quick. Obviously, as I mentioned, stroke is a big part of our practice. And so when patients present with large vessel occlusions, I think this is one of the more rewarding things that we do. Here you can see a left M1 occlusion right there. And so now we have these catheters that you can essentially just push without even any wires. It will go up to the artery, so you can see here. And here's my aspiration catheter, and I'm pushing it into the clot while performing aspiration. And then you have these big bore catheters that you bring up for support, and additional aspiration. And again, this whole procedure, and then here's your reperfusion right here. As you can see, the whole procedure takes about 20-25 minutes. Now, obviously, not every case is pretty straightforward because some people have intracranial calcifications or atherosclerotic disease or difficult arch, and obviously those all make things challenging. But by and far, if the case is straightforward, then it doesn't take more than 15-20 minutes. Here's a postoperative MRI of the patient I just showed you. You can see just minimal stroke hits here and there in the deep area, but other than that, pretty good. Patient essentially was almost back to baseline, and went home like 2 days later. In older days, obviously, this patient will get a massive stroke and will need to go under decompressive hemicrania and all those things. So I think stroke is a surgical pathology, and as proceduralists, either neurologists or surgeons should essentially own this problem. We do see a lot of moya, as you know, it's a steno-occlusive disease. Obviously, a big part of our practice is that. I see patients like these all the time that have strokes or TIAs, and then you do the angiogram, and their blood vessels sort of look like this. So here's a normal angiogram, here's a moya angiogram, with this complete occlusion of the ICA. And so essentially STA-MCA bypass, or either direct or indirect bypass, is a great way. I try to prefer to do direct bypasses because it provides instant revascularization as much as possible. Obviously, it takes more time and maybe slightly more risky, but I think in adults, I think it works great. So again, just a very quick video here where you can expose the STA real quick. You do a craniotomy. You find your MCA recipient branches a lot of times, and then you put the background material right there. You prepare your graft, the STA. You put clips on either side of those of that MCA, and then you sort of open the artery right here, and then so here's opening the MCA vessel right there. You flush it with heparinized saline, and then you can just take your STA and start suturing. This is about a 9-0 or a 10-0 proline, or nylon, excuse me. But you have to be just obviously it needs a lot of practice because it's the vessel size and the suture material is very delicate. So obviously it's technically challenging, but once you're able to do it, it's actually a very rewarding case. And then so here you can see it forms what we call as an elephant foot, as you can see. And once you do that, and once you take the clips off, here's a clip on the S. So you're taking the clips off the MCA, and here's your essentially bypass completed. So patients will do really well with that. So this is before surgery in one of the moya patients, and then after the STA-MCA bypass, you can see the STA really supplying all this MCA branches, and this patient specifically did not have any future strokes, but he was having about, I think, 1 or 2 episodes a month, and then so you can see all the revascularization here. And sometimes you have to do bypasses for aneurysms, right? So if there's a complex aneurysm that you cannot clip or has to be resected, or then you have to replace their flow with doing a bypass. And so I think this is the last video here. This is a lady that presented with this giant fusiform pica aneurysm. Here you can see, obviously it's partially thrombosed, although on the angiogram it looks like a small aneurysm, but in essence it's a massive aneurysm because most of it is thrombosed, right? So all you see is just this, but you can see on the MRI that I showed, it's a massive. So what you have to do is, in these cases, obviously you cannot coil it, and the mass is pushing on the brainstem. So in this case, I found the pica. We cut the pica from the aneurysm, as you can see right here. So that's proximal pica and distal pica right there. right? So the aneurysm is excluded. So here's the aneurysm. Then we brought the two ends of the pica together, as you can see right here. So because it's a proximal pica, it's important to preserve it. Distal pica you can sacrifice without any problems, but proximal pica, if you don't, there are perforators that come out from those segments, and patients can get Wallenberg brainstem infarct syndromes. So essentially, yeah, put the pica back together, and then you'll see the pica here looks revascularized, looks really good now. So it's flowing nicely, no issues there. You can confirm the flow with the Doppler. So this is the Doppler probe that we're inseminating the vessel. You can do the ICG. So here you can see the pica looking really good right there. Nice flow. And then you can go into the aneurysm because now it's completely devascularized. You can use an ultrasonic aspirator, debulk it, and then resect it as much as you can and take the pressure off the brainstem. So next frontiers, as I talked about earlier, we are doing a lot of middle meningeal artery embolizations because that has now in recent trials have shown that the recurrence rate of chronic subdural hematomas reduces by almost 3 times in these patients. So every time there's a chronic subdural hematoma, I will drain it surgically, and then I'll go up the middle meningeal artery and embolize the membranes. Obviously, you have to go as distal as possible because that's where the membranes are. You don't want to be proximal because then you can at the foramen spinosum, you can hurt the facial nerve ganglion and other critical neurovascular structures. And then intraarterial chemotherapy. This is a retinoblastoma, so we inject chemotherapy through the ophthalmic artery using endovascular techniques. And in most patients, in a lot of patients, like here you can see, this is the globe right here. This is the ophthalmic artery. You can see the microcatheter tube. And once you get the catheter in the ophthalmic artery, you can inject the chemotherapy to really treat your retinoblastoma. I think we will stop here, and I will take questions because I know I've gone way over time. The last comment would be that being endovascular trained, you can help all these different specialties, right? So for neurosurgery, you can do aneurysm AVMs. For neurology, stroke. You can do water testing. For ENT, you can help with BTO, a balloon test occlusion. You can help them with epistaxis embolization, and oncology and chemotherapy, pediatric retinoblastoma. So the impact for being endovascular trained, I think, is massive. And with that, I'll take any questions.
Thank you
Good
very much.
evening. Thank you for the presentation, Dr. Aqueel. Actually, we have 2 questions from Dr. Mustafa Karim. Dr. Mustafa asking if after embolizing the AV fistula, do you recommend resecting them later?
Yeah, so that's a great question. So if we're talking about just AV fistulas, they are different from AVMs. In AV fistulas, you have
Sorry, Dr. Mustafa. Did you repeat, Dr. Mustafa? Dr. Mustafa?
Okay. So in AV
البنات دزيت لهم الرابط فما دخلوا بيها فزينب ما تحملت وطلعت قالت انا ما اتحمل هيك مناظر طلعت سلسبي قاعده تسوي يعني هو شوي لك انت
عفوا بس الصوت بدون زحمه
ها
الصوت
فقالت انا الحمد لله افتهم كلمه قلت لهم بالنهايه قلت لهم حبايبي الجراحه
دكتوره زينب حيدر. دكتوره زينب حيدر, please go.
All right. So for AV fistulas,
Sorry,
that's okay. It happens. So for AV fistulas, it's important to block off the draining vein. That is the idea, right? So when it's either surgically or endovascularly, if you can block the vein which is draining the fistula completely, that will kill the fistula. So you don't have to go in and resect it. So that's why what I was showing you before in the cases that where there was a petrosal or a posterior fossa fistula and an anterior fossa fistula, all we have to do is just basically go and take down the draining vein, and that kills the fistula. You don't have to resect it, the fistula itself. If you're able to block the vein completely with endovascular, like by putting glue or onyx or whatever, if the vein completely dies, you don't have to take them to surgery to resect them. And then I think the second question is about ischemic stroke. If we use intra-arterial TPA at my center.
Yes. Yes, Doctor.
It is.
Regarding the ischemic stroke, do you use intra-arterial TPA at your center?
So sometimes, I think I would say 90% of the times when we do the thrombectomy, and if we get a good revascularization like TICI-2B or TICI-2C, we typically will not use it because a lot of times we are doing these strokes which already have an established core or a large core. So we are worried about post-reperfusion hemorrhage, which can be worse with TPA. But every now and then, if we get into a situation where we feel like that there's not a large core, if there's a big vessel that's very distal and secluded and we cannot get to it, then we will do it. Then we will do the intra-arterial TPA, but it's on a case-by-case basis. It's definitely not a routine practice.
Okay, thank you, Doctor. Now we'll be back to Dr. Ali Abdul Karim.
Yes.
Thank you, Dr. Israa. Please, Dr. Mohammad, did you hear me?
Yes, yes.
Did you have any comments?
Thank you, Dr. Aqueel, about this great scientific up-to-date lecture that are dealing with different cases and the neurointervention procedures. And especially you are mixing between open surgery and endovascular surgery, which is, I think, is a very great approach to some of the cases that may be treated endovascularly, but the treatment will be not complete, and we need neurosurgical intervention in other way. I have one question that what's your guideline for accidentally discover AV malformation? Patient presented with seizure or patient presented with headache, and we discovered that there is AV malformation and it with Martin Sparks score 3 or 4. What is your guideline? Do you treat it surgically or endovascularly?
Right. So that's a very good question, and obviously this will take a long time. But in a nutshell, I know a lot of people will refer to the Aruba trial when they talk about high risk of complications with treatment. But Aruba trial in itself have a lot of problems. It was a very, very poorly done trial. It is, I think, in my view, it is a horrible trial. Actually, I will tell you this, that since Aruba was published, a lot of primary care doctors see these patients in the community with AVMs, and they basically tell them, hey, listen, Aruba suggests that you should not get treatment, so they don't get treatment. And now we're seeing a lot of these patients after Aruba that are now coming to us with ruptured AVMs. So AVM is not as benign of a pathology that everybody thinks. The problem with Aruba is most of the centers that treated those AVMs were not specialized. They were in Europe. They only treated partially. They treated those AVMs partially, like either with partial embolization or partial radiosurgery or radiation, because they don't have a lot of surgeons in Europe that does AVM resections. And the most important learning point in AVM is that if you want to treat them, you have to treat them completely. You cannot do partial treatment because partially treated AVM is more dangerous than a fully treated AVM. And so with that in mind, obviously the Aruba trial results are so bad because they have so many complications, because a lot of these patients had hemorrhage or strokes because they were partially treated. Now, coming back to the point, to your question, if I see a patient with a Spätzle-Martin 3 or 4 AVM, first of all, I'll have to see the demographics, right? How old or how young the patient is, if they're healthy or not, what symptoms were they having, and then how safe is it to treat this AVM and whether I can completely treat this AVM or not. If I recently saw a patient who has an AVM that occupies his entire cerebellar hemisphere, the whole hemisphere is AVM, right? Obviously, I will not offer treatment to that patient because I will not be able to completely resect it. I'll probably give him a lot of complications or morbidities. And so I told them, we're not going to treat this. But on the other side, I had a patient who had a 6-centimeter AVM. She's a young 20-year-old, came with seizures, and she's 20, and it's a 5-centimeter AVM. It had multiple feeders. And so what I did was, in her case, I basically took 3 different sessions of embolizations. I embolized her AVM through ACA, MCA, and PCA feeders. And once I had the flow down to like about 20% of what it was originally, then I took her to the operating room and I resected that AVM. And so with surgery, she did develop a small stroke and had some weakness on the opposite side. But now with therapy, she's almost completely intact. She's gone to work. She's seizure free, and she's doing great. So I think I will use the Spencer-Martin grading, and I'll use the Lawton-Young grading, and I'll put the scores together. And then I'll talk to the patient and I'll say, listen, you have an AVM. We'll talk about the risk of hemorrhage. So the risk of hemorrhage is, more or less 1% per year. But if somebody is 20 years old, and at least in the US, if they're living to be, let's say, 70 years old, they have a 50% risk of hemorrhage over their lifetime. And that's a pretty significant risk. But let's say if somebody is 70 years old and have a Spencer-Martin, even a 2 AVM, I don't think I'm going to treat it, because if they're 70, the risk of hemorrhage for the next 10 years is probably like between 5 and 10%, right? But the risk of them having complications from anesthesia or surgery, if that's 5%, then it's not worth treating that AVM.
Thank you so much. I agree with you that all the neuro interventionists, they don't satisfy with Aruba. And the problem with Aruba that the selection of the patient is not include all the type of AV malformation, all the size. And for this reason, I think it is there was a bias in regarding this study. Another question I want to ask you that if you find high risk AV malformation and there is multiple feeders and there is one draining vein, do you go? Do you prefer to treat this case endovascularly or neurosurgically? Because there will be risk of increasing venous rupture and venous hypertension and hemorrhage if there is one drain.
Right. So yeah. So I don't, even if there's one draining vein, I don't have a problem treating them with endovascular means. But I will say this, that when I do endovascular treatment of AVMs, my intention is not to completely cure the AVM. I'm just trying to take the perical arterial feeders down so that I have less bleeding and easy access, and the AVM is not as angry when I go in. So if I feel like there is an AVM that has, let's say there's a parietal AVM and the feeders are deep to the AVM, so that surgically when I go in, the first thing I'll see is the AVM and I'll not see the feeders first. In those cases, I feel that endovascular embolization is very critical, because I can get control of those feeders endovascularly. So when I go in, the AVM is not as dangerous. On the flip side, if there's a superficial AVM and the MCA is feeding it and the MCA feeders are all on the surface, then I might not do endovascular embolization on them, and I might just take them to surgery. But to your question, if they have one draining vein or more than one draining vein, really does not affect my decision making. However, if there's a single draining vein and if there's significant stenosis of that vein, then I would be very, very aggressive in counseling the patient to get that AVM treated, because that AVM is just waiting to rupture at some point in time.
Thank you so much. I also call my colleague, Dr. Yasser. He's our guest also today, if he has any question, because the subject is dealing with a neurosurgeon colleague, but more than a neurologist. So I think Dr. Yasser is with us. Dr. Yasser Hamandi with us also. I think he don't hear me.
Dr. Ahmed Jalil Al-Asadi have a question.
Yeah, Dr. Ahmed.
Assalamu alaikum. Thank you, sir, for the valuable information. As you mentioned that you visit Iraq, and be sure our home is our homes. It is your home. And the next time, inshallah.
Thank you. Inshallah. Thank you very much.
I